Alright, hello everybody. So today we'll be talking about endocrinological emergencies in the ICU. Endocrinological disorders are one of the disorders that we encounter frequently in the ICU. Some of them are pretty much common, some of them are rare. However, we always would need a clinical suspicion to approach those disorders, as some of them would need to be treated before the other labs are back. However, when we talk about endocrinological emergencies, one of the most common endocrinological disorder we encounter in the ICU is diabetes. It's the most common endocrinopathy anyway, as in the inpatient, outpatient, as well as in the ICU. Every fifth or sixth admission in the ICU, that patient would suffer from diabetes. It could result in a life-threatening complications that include hypoglycemia or hyperglycemia, as it would result in a deranged metabolic profile, electrolyte abnormalities, disturbances in the renal function, dehydration, and low immunity, as well as patients with autonomic neuropathy. Among those diabetic patients, they are highly vulnerable for nerve injuries in the ICU, as well as bed sores, soft tissue trauma, delayed feeding, as in gastroparesis, as well as hemodynamic instability. And the one that we most commonly encounter in the ICU is the DKA. DKA is mostly the DKA we see are insulin-dependent patients, which is type 1 diabetes, and occasionally it can happen in type 2 diabetes. The insulin deficiency would lead to reduction of glucose uptake and its utilization by muscle, fat, and liver. The DKA condition would result in glycogenolysis, glucogenesis as well. Those patients will have increased lipolysis, which would explain the reason that we would have elevated ketone bodies, which could be presented as acetone bodies or beta hydroxybutyrate. That's why we would have an anion gap metabolic acidosis. Presentation, as we all know, obviously it's dehydration secondary to osmotic diuresis due to volume depletion, which would result in hypertension or even orthostatic hypertension. The symptoms are, as we know, polyuria, polydipsia, tachycardia, and lethargy. And since they come acidotic, they would have decrease in their sensorium. So it might range from mild confusion to coma, as well as other symptoms such as nausea, vomiting, abdominal pain, cosmal respiration, and fruity breath because of the acidosis. The underlying precipitating conditions could be non-compliance, patients are not taking their insulin, their hypoglycemic medications, or a superimposed infection, as well as de novo. Patients who were not previously diagnosed with diabetes would present for the first time with DKA. Mostly happens in the pediatric population. However, whenever we talk about ketosis, we need to keep in the back of our minds that the differential diagnosis is alcohol and starvation as well. In the lab, as we know, there's hyperglycemia, urine serum ketones, decreased bicarb, elevated anion gap, azotemia, hyperkalemia. However, the potassium might be elevated, but the overall body is deficit for the potassium. The sodium can vary depending on the level of the glucose and the hydration level as well. If we check an ABG, we can see hypocapnia, which is a compensatory mechanism to the metabolic acidosis. The treatment, obviously, it's hydration, volume expansion with isotonic fluids, normal saline preferably, and usually we start with aggressive hydration. We can also give insulin as a bolus between 0.1 to 0.15 units per kg, as well as starting an infusion of IV insulin at rate of 0.1 per kg per hour. Our goal is to decrease the glucose levels by 75 milligrams per hour. However, if we don't reach this level, we can always increase the IV infusion. And once the intravascular volume is restored and the blood sugar is less than 200, we can start with half normal saline. The other thing is, once the anion gap normalizes and the patient starts to have oral intake, we can switch from the IV insulin to the sub-Q insulin, but it's preferable to have overlap between the IV insulin and the sub-Q insulin, about 30 minutes. And we'll need to measure the glucose hourly to adjust the treatment. However, keep in mind that the finger stick may be lower than the venous in patients with hypertension. And the lights will need to be measured from 2 to 4 hours, as well as following the anion gap to adjust the treatment. Potassium will need to be supplied as the total potassium level is low. Phosphorus, generally it's not being replaced. However, if the phosphorus is less than 0.1, then it would need to be replaced. Sodium bicarb, usually it's not required in patients with DKA, because as long as the DKA is being corrected, the acidosis would spontaneously be corrected as well. However, if we need to use the bicarb drip, we need to calculate the total deficit, and half of that amount can be given as bolus, and then start an infusion over the 8 hours. Again, as we said, once the anion gap normalizes and the patient starts PO intake, at that point we can switch the insulin from IV to sub-Q. The other diabetes complication that we would see is the hyperosmolar non-ketotic syndrome. Usually happens in elderly patients, type 2 diabetics. They present with severe dehydration. Urine analysis would show that they have glucosuria. Their blood sugars are very high. However, there is no ketosis. And the sodium might be low, as they would have hyperglycemia, which would eventually lower the sodium. That's why we can always use the corrected sodium equation in order to have accurate readings of the sodium. Treatment is the same as DKA. We give volume replacement, hydration, resuscitation, and insulin as well. The big topic is glucose control in the ICU. One of the big trials that we see in the ICU is the NICE sugar study. This study came because the hyperglycemia is a controversial topic in the ICU, at what level it should be controlled, and previous trials and meta-analysis had confusing conclusions of the intensive glycemic control. Therefore, the NICE sugar study had compared between the intensive glucose control, where the blood sugar will be in the range of 81 to 108, versus the conventional glucose control, where it's less than 180. The study included about 6,000 patients. They were recruited from 42 hospitals from across Australia, New Zealand, and Canada. The inclusion criteria for this study included a minimum of 3 consecutive days in the ICU, and the exclusion criteria included those patients who were expected to start oral intake in the next day, or they have already been in the ICU for more than 24 hours, or expected to die imminently, or they were unable to provide consent for various reasons, such as mental status change or something. The patients, they were randomly assigned. They were assigned to either the intensive glucose control or the conventional glucose control group. Again, the intensive glucose control, the range of the glucose was in the 81 up to 108, and the conventional glucose control was less than 180. The glucose was controlled with IV infusion of insulin, and the intervention was stopped whenever patients would start eating or they were discharged from the ICU. The primary outcome of this study, they looked at the death from any cause after 90 days from the initiation of the study, and the secondary outcomes included the survival time in the first 90 days, cause-specific death, the duration of the mechanical ventilation, as well as the renal replacement therapy, ICU stay, and the hospital stay. So the results of the NICE sugar study, it showed that the intensive glucose control significantly increased in mortality at 90 days, As the odds ratio was 1.1, the absolute risk increase was 2.6% and number needed to harm was 38. The incidence of severe hypoglycemia was significantly higher in patients undergoing intensive glucose control, as the odds ratio was 14.7. Also, there were no significant differences between the groups in the duration of the mechanical ventilation or renal replacement requirements. And there was no significant difference between the groups in terms of the duration of the stay in the ICU or the total stay in the hospital, as the p-value was for the hospital ICU stay was 0.84%, and for the total hospital stay was p-value was 0.86%, which is higher than 0.05, which makes it insignificant. So as a conclusion for the NICE sugar study, the intensive glycemic control in critically ill patients significantly increases the mortality at 90 days when compared to the conventional glycemic control. The incidence of hypoglycemia was higher in patients receiving the intensive glycemic control. Hypoglycemia is also one of the things we encounter in the ICU. Obviously low blood sugar, which would result in adrenergic response, including nervousness, tachycardia, diaphoresis, but the most critical manifestation could be a seizure. There are different pathophysiologies for hypoglycemia. One of them includes the decreased insulin resistance, which is secondary to weight loss, adrenal or pituitary insufficiency, or decrease in the clearance of insulin, secondary to renal or hepatic failure, or drug interaction, which might lead to hypoglycemia, or reduced oral intake. The patient is not eating and they're getting their normal insulin dose to result in hypoglycemia. The treatment, as we all know, is D50. However, if it's refractory, we can use glucagon, hydrocortisone, or octreotide. Patients with oral intake and they're having frequent hypoglycemia, it's preferable to avoid the long-acting insulin, as we can use the rapid-acting insulin instead, which can be titrated according to the meal and the levels we get, as well as at the time. Moving to the other disorder we see in the ICU is thyroid disorder. In thyroid disease, basically we need to have a high clinical suspicion, as they would require treatment immediately, as the labs will need time until we get them back. So I have a question here. Edema Coma is all of the following except A. Precipitated by stress, cold exposure, and opiates, treated only when the diagnosis is confirmed by lab testing, or it's capable of producing hypercapnia, more common in women. Yes, that's correct. It needs to be treated before we get the labs back. Otherwise, it could be precipitated by stress, cold exposure, and it's capable of producing hypercapnia. As patients with Edema Coma, they would have hypoventilation and they would retain the CO2. And for some reason, women here are unlucky, they get it more common than men. Edema Coma, the presentations, as we know, is CNS depression, delayed deep tendon reflexes, hypothermia, bradycardia, dry skin. They can have hyponatremia, anemia, hypercapnia, hyperlipidemia, elevated CPK, hypoglycemia alone, or even with adrenal insufficiency. And again, it's more common in women than in men. The features, as we all know, is dry hair, lateral eyebrows are thin, the periorbital edema, and puffy dull face with a dry skin. The causes could be undiagnosed hypothyroid, which patients they would present for the first time to the ED where they were not diagnosed before with hypothyroid. They're not taking their medications, or they had a recent ablation for their thyroid gland. Also, drugs can cause hypothyroid that can result in Edema Coma, such as amio propylthiouracil, lithium sulfonamides. And the precipitating factors, as we said, are cold exposure, sedatives, and stress and MI. Diagnosis number 1 is clinical, and we would see elevated TSH, low T3, T4. The other findings could include hyponatremia, kalemia, hypoglycemia, hypercapnia, and respiratory acidosis. The treatment for Edema Coma is based on the clinical suspicion, so we may draw the labs. However, we're not going to wait until we get the results back, as it will take time, and then we can start treatment with IV thyroxine. The loading dose is 300 mics, and then daily somewhere between 50 and 100 mics. IV T3, which is the triiodothyronine, the dose is between 10 and 20. I don't think we have this in our institution. And they should be treated also for adrenal insufficiency, as sometimes they would be concomitantly together. And it will be treated with hydrocortisone of 300 milligrams once. And obviously, the precipitating causes will need to be treated, as well as supportive measures such as intubation for airway protection and nutrition. I was looking about the hypothyroid and critically ill patients, so I found one of the studies which talks about hypothyroid and failure to wean in patients who are receiving prolonged mechanical ventilation. So we all know is that hypothyroid is not that common. However, it could be a ventilator-dependent respiratory failure manifestations. And the objective of the study was to find out the percentage of hypothyroid among those patients with prolonged mechanical ventilation. The definition in this study of the prolonged mechanical ventilation was more than 3 weeks. And this study was a retrospective study. So they reviewed 173 patients. 140 patients, they had screening of the TSH at admission. They also collected different data, including age, sex, BMI, serum TSH, number of patients who were previously diagnosed with the hypothyroid, and number of patients with hypothyroidism that's diagnosed clinically and by lab tests during their stay in the hospital. The primary outcome was liberation from the prolonged mechanical ventilation. In other words, it's being off the vent for more than 1 week. The results of the 140 patients, only one patient was previously diagnosed with hypothyroid. The clinical diagnosis of hypothyroid was made in 4 of the patients out of the 140, and it was confirmed with a lab test of the TSH, T3, T4, and they were treated with thyroid supplements. Among those 4 patients, 3 of them were successfully extubated, and the 4th one has died from other causes. Of the 140 patients that were enrolled in this study, 92 patients were weaned from the prolonged mechanical ventilation and 48 were not weaned. The mean serum TSH was 4.2 in patients liberated from the mechanical ventilation. However, in the patients who were not weaned, the TSH was 4 plus minus 4.7. And that's not statistically significant. So basically, if the patient has normal TSH, that doesn't mean the patient will be weaned off the vent, as there are other causes for failure to wean from the vent. So as a conclusion of this study, hypothyroid is an uncommon cause of failure to wean in patients who are on prolonged mechanical ventilation. It's just 3%. However, it's potentially treatable cause and should be considered in all patients who fail to wean. However, normal TSH would not justify a patient not being extubated and weaned from the mechanical ventilation. Why patients have respiratory failure in hypothyroid? It's basically because they have hypoxic and hypercapnic ventilatory drive that's decreased, and they have respiratory muscle weakness, which include diaphragm dysfunction and skeletal muscle myopathy, as well as alveolar hypoventilation, sleep apnea, or other mechanical causes such as pleural or pericardial effusion, which would affect the wean trial from the vent. We were talking about hypothyroid and edema coma. We can now move to thyroid toxicosis and thyroid storm. It's a scary condition. It's life-threatening that usually has severe hypothyroid manifestations, and it occurs in less of 10% of the hospitalized patients with thyroid toxicosis, and it's again 9 to 10 times more common in women than in men. The thyroid symptoms, as we all know, it's high-grade fever, cardiac symptoms, which could be AFib, flutter, SVT, or neurological symptoms, which could be tremor, delirium, psychosis, or even a coma. Hypertension, tachycardia, hyperreflexia, they are all symptoms of thyroid toxicosis as well. I found this table on UpToDate, which basically gives a score for patients with thyroid toxicosis, and this scores basically depends on the severity of the symptoms they present with. So for example, their fever, the higher it is, the higher score they would get. So if the fever is more than 104, this would give them a score of 30. However, if they didn't have fever, they would take a score of 5. Same thing for the CNS symptoms. The more severe symptoms, such as seizure, coma, they would get a score of 30. GI symptoms, cardiovascular symptoms. In cardiovascular, we can see here that with AFib patients, they get a score of 10. However, if the heart rate is high, more than 140, they would get a score of 25. Also, the heart failure would affect the score and previous history. So after calculating the score from each symptom, if the score is more than 45, this means they are at high risk for thyroid toxicosis. However, if it's in the range of 25 to 44, it supports the diagnosis, but it's not confirmed. But if it's less than 25, this is unlikely to be a thyroid toxicosis or a thyroid storm.
Yes, sir?
Yeah.
I'm just struck by their statement of 45 or more being highly suggestive of
Highly
thyroid
suggestive.
storm.
Most of our patients.
Every one of our patients would have 45.
They would have 5,
So
yeah.
do you know when they looked at this, what population of patients they used this scoring system in?
I'm not sure about which population, but I think you need to have the suspicion of thyroid storm and then go to this criteria.
Yeah.
So because if we have
see the negative predictive value would be useful,
Yeah.
but
yeah, but if it's high, it could be anything. It could be sepsis, could be anything. Yeah, because in septic patient, if he has high fever with tachycardia, so like 140 and high fever, this is 30 plus 25. That's a
very, very easy to get to 45.
yeah, especially in our patients. Yeah. Precipitating factors for thyroid toxicosis: infection, DKA, surgery, trauma, PE, or trauma or surgical manipulation of the thyroid gland itself, iodine administration, or discontinuation of the antithyroid medications. The diagnosis, obviously, it's elevated T3 and T4 with low TSH. This is the most common thing. However, there's other variants which are uncommon, such as only T3 thyrotoxicosis, which means that T4 is normal level, and central hyperthyroidism, which is the least common, which will have the TSH, T3, T4, all of them will be elevated. Treatment starts with a clinical diagnosis. Labs need to be drawn, obviously, but we can start treatment prior to that. We start with supportive therapy and symptomatic treatment, respiratory support, hemodynamic support, and controlling of the hyperthermia. The treatment for the thyroid storm would basically blocking agents of the thyroid hormone synthesis, which includes propylthiouracil, or we can use methimazole. Also blocking the release of the thyroid hormone with iodine. However, keep in mind the iodine should be used only after blocking the synthesis. Other mechanisms to decrease the conversion of T4 to T3 includes the propylthiouracil, hydrocortisone, propranolol. And beta blockers have other benefits, which include the controlling the hyperadrenergic symptoms, and we can use propranolol 1 milligram increments in 10 to 15 minutes, and esmolol could be used as well for the treatment of the thyroid storm. Some cases are difficult to treat, and in those cases plasmapheresis could be used, exchange or peritoneal dialysis can be used to remove the circulating thyroid hormone.
So it's not clear in the sense of I'll wait for labs before I treat. Or I mean, if an infection precipitates a thyroid storm, then
It'd be hard to do something.
it's going to be hard.
It's difficult to differentiate.
I mean,
But part of the treatment is treating the underlying
You're right.
cause. Yeah. Moving to adrenal crisis. So, which is not a cause of adrenal insufficiency? Etomidate, postpartum state, ketoconazole, or isoniazide? D. Yes. So, primary causes for the adrenal crisis include Addison's disease, bilateral adrenal hemorrhage, abrupt withdrawal of exogenous steroids, TB, septic shock, meningococcemia, malignancy, amyloidosis. Drugs that would cause adrenal insufficiency, they include etomidate and ketoconazole. Presentation, hyperpigmentation, dehydration, hyperkalemia. Secondary causes includes craniopharyngioma, postoperative complications, postpartum hypopituitarism, such as in Sheehan syndrome, where there will be pituitary bleed, infiltrative diseases such as hemochromatosis, sarcoidosis, or again withdrawal of steroids.
I don't know. Have you come across if there's a dose relationship with accommodate the insufficiency?
Yeah, we're coming to that. Presentation, obviously hypotension, nausea, vomiting, fatigue, anorexia, depression, amenorrhea. Remember, in bilateral adrenal hemorrhage or infarction, they present with abdominal pain, lower back and chest pains. The risk for the bleed could be anticoagulation or in the postoperative state. And the labs, they include hyponatremia and hyperkalemia. Testing for the adrenal function. If the cortisol level is more than 20, the diagnosis is unlikely. The adrenal function test is the same test where we can use 250 mics of concentropin and then checking the cortisol level at 0, 30, and 60 minutes. If the increase of cortisol is more than 7, or an absolute increase is greater than 17, that includes the adrenal insufficiency. Treatment would be steroids and correcting the hypovolemic state with normal saline isotonic fluids. Hypotonic fluids should be avoided as patients would be hyponatremic and could worsen the hyponatremia. So whenever we talk about adrenal crisis, we talk about two studies which talk about the effect of steroids and septic shock. So one of them is the ANAN study, which was published in JAMA in 2002, which looks at the effects of treatment with low doses of hydrocortisone and fludrocortisone on the mortality in patients with septic shock. The objective of the study was to assess if low doses of corticosteroids would improve the 28-day survival in patients with septic shock and the relative adrenal insufficiency. The design of the study was placebo-controlled, randomized, double-blind trial. The study was done in France. It included 19 ICUs, and the study was done for patients who were in the ICU in the period of time between 95 and 99. Patients that were included in the study, there were 300 who filled the criteria for a septic shock, and they were enrolled after they got the concentropin test. So there were two groups. The first group had steroids, hydrocortisone plus fludrocortisone, and a matching placebo for the other group of the patients. So the two groups, one of them included 151 patients and the other included 149 patients. The treatment was a total of 7 days. And the main outcome that was measured is 28-day survival in patients with relative adrenal insufficiency, mostly in the non-responders to the concentropin test. So the results of the study showed that 229 non-responders to the concentropin, they were divided into the placebo group and the steroid group, and 70 of the responders were also divided into the placebo and the steroid group. In the non-responders, there were 73 deaths, which is 36%, in the placebo group, and 60 deaths in the steroid group. This would make it a p-value of 0.02, which is significant. Also, they looked at the vasopressor withdrawal within 28 days in 40% of patients in placebo group and 65 patients, which is 57%, in the steroid group were able to withdraw from the vasopressors, which makes it a p-value of 0.001, which is less than 0.05. That makes it significant. However, in the responders who did respond to the concentropin test, there was no difference. So, as a conclusion for this study, a 7-day treatment with low dose of hydrocortisone and fludrocortisone significantly reduced the risk of death in patients with septic shock and relative adrenal insufficiency without increasing any adverse effects. The other big study that was also done for adrenal insufficiency in sepsis is the Corticus. It's a multi-center randomized double-blind placebo-controlled trial. It had about 500 patients. 50% of them, which is 251 patients, received hydrocortisone 50 milligrams, and the other group were in the placebo group. The primary outcome was death at 28 days in patients who did not respond to the concentropin test. Again, in the non-responders we're looking here. So the results of the Corticus in a summary, there was no significant difference in mortality. However, the shock reversal in 2 days was higher, but on the other hand, there was more hyperglycemia, more superimposed infection, new sepsis, and new septic shock. However, for the mortality, again, there was no difference. In the ICU, we always talk about etomidate that causes adrenal insufficiency, so I found this study which compares etomidate to other agents, ketamine in this study, in rapid sequence intubation. So here they looked at a 28-day morbidity after a single dose of etomidate or ketamine use in the emergency intubation in critically ill patients. The study here was randomized, controlled, single-blind. Patients were randomly assigned to both groups, either the etomidate or the ketamine. The etomidate group included 328 patients, and they received 0.3 milligram per kg of the etomidate. In the ketamine group, there were 327 patients, and they got 2 milligrams per kg. It's a single-blind study, so the emergency physician who was enrolling the patients was aware of patients and what medications they're getting. The primary endpoint was the SOFA score, which is the sequential organ failure assessment during the first 3 days in the ICU. The patients who were excluded who died before reaching the hospital or those discharged from the ICU before 3 days. So the results of the study showed that there's 234 patients were analyzed in the etomidate group and 235 were in the ketamine group. The SOFA score was not significantly different among the two patients, so they were both as sick as other. The SOFA score was 10.3 for the etomidate versus 9.6, and that's not statistically significant, as the p-score was 0.056. And the intubation condition did not differ significantly between the two groups. So as the result here shows that the percentage of patients who had adrenal insufficiency was significantly higher among the etomidate group than in the ketamine group. The odds ratio was 6.7. This supports that the etomidate is a reason for the adrenal insufficiency for patients in the ICU. Other emergency disorders, which we don't see that much, but are pituitary disorders. They happen in the postpartum, panhypopituitarism, bleeding, patients operated for pituitary tumors, or stress-induced hypopituitarism. It's not that common, however, when it happens, the most common one we would see is diabetes insipidus, which in those patients, it's a central diabetes insipidus, obviously, and the majority of cases they would resolve spontaneously, and some of them would still have residual effect of absolute ADH deficiency, and the treatment for those patients would include desmopressin, which can be given orally or nasally or even IV. Any questions?
In the etomidate ketamine study,
Yeah.
Were there any clinical differences between the two groups?
So they calculated the SOFA assessment, which is calculates the mortality rate for patients being admitted to the hospital. It's similar to the MPM and the Apache score. So they both had similar score, which is, here they mentioned it's 10.3.
They looked at?
The SOFA score.
They didn't look at like mortality, length of stay, dating events?
The mortality, no, that was not included. But they were as sick as both groups had the same SOFA score.
Was anything related to the dose?
They were given the same dose, which is 3.3 milligrams per kg.
We never used the dose, so 2.2, but that's never, even anesthesia wouldn't push that. They would always push probably 0.1, right? It doesn't matter.
I would push it.
In the ER, we always use 0.3.
You do 0.3. Anesthesia always uses lower dose. I've been using 0.2 or less, and because anesthesia does that.
Yeah.
You do 0.3. Okay.
So, I mean, if you're getting your patient from us.
It's 0.3.
Thank you.
If we get a patient from the ED who has adrenal insufficiency, it's probably 0.3.
No, it's because pharmacy, like when we're in our recess rooms and or if we do any intubation, pharmacy's there and they pull up all the drugs and they weight base everything and it's
And that said, when did they do the cortisone stim relative to when they gave the etomidate?
I think it's on admission to the ICU. So it all started in the ED,
Right.
and then once they got to the ICU,
They did
the stem test.